Hello, good afternoon. My name is Hai Simhan. I'm a maternal fetal medicine physician at UPMC Magee-Womens Hospital and the Vice Chair for Obstetrics for our Department of OB/GYN. I also have the privilege of being the Director of Clinical Innovation for the Women's Health Service Line. I'm really excited to be a participant in this next session, which will be about telehealth and digital engagement, and looking forward, in this case, to 2025 or perhaps beyond. And we have a terrific keynote as well as what I think will be an engaging and informative panel discussion to follow. First, I'll start with introducing our fabulous keynote speaker. Cece Connolly is the President and CEO of the Alliance of Community Health Plans. This ACHP is a trade association for nonprofit community health plans. A prominent voice in U.S. healthcare, she has a deep understanding of journalism, policy, and politics, as well as health plans, payers, and providers. Cece served as a national correspondent for the Washington Post and a leader at international consulting firms, including PwC and McKinsey. She's the co-author of Landmark, The Inside Story of America's Health Law and What It Means for us all, and has been published in numerous publications, including the New England Journal of Medicine. Connolly was included on Business Insider's inaugural list of DC healthcare power players and was also the first non-physician to receive the prestigious Mayo Clinic Plumber Society Award for promoting deeper understanding of science and medicine. Cece will be speaking to us today about telehealth and digital engagement in 2025. Please join me in welcoming Cece Connolly to the stage. Thank you.
Thank you, Hai, for that warm introduction. It sounds as if Hai put in a call to my mother, but it was very kind. I can't tell you how excited I am to be out of Washington, be out of my house, be out of my pajamas, and be here with all of you. And I know that we have many others joining virtually, and so I'm looking forward to the engagement, both here and via cyber. A tiny bit more about the perspective. Hai mentioned that I lead an organization called the Alliance of Community Health Plans. And I just want to share with you another word or two about that organization because it really informs the perspective that I hope to bring to you today. And also, I just have to say that UPMC is one of our all-star members at ACHP. And so I'm so grateful that they're hosting this event. And we've been visiting with many of the leaders there on this trip to Pittsburgh. ACHP, all of our members are nonprofit, provider-aligned community health plans, such as ACHP, because we believe very strongly in that model of plans and providers coming together and partnering on behalf of patients. And we're going to talk more about that model and why I think that telehealth is the perfect fit for that going forward and looking to 2025. But let's start with a tiny bit of audience participation here, if I can. I'm not going to make you do any yoga stretches, but I want a little show of hands. All of you that have come to this conference as you've been networking and catching up with long-lost friends, raise your hand if you've been comparing some COVID stories, talking about how long you've been stuck at home. Are you going back to the office? What booster are you going to get? Are you thinking of mixing and matching, right? So clearly, the pandemic does not just dominate our lives, but for many of us, especially those of us in the health sector, it has been our lives for nearly 2 years. Now, one more show of hands. Who in the past 2 years has had the opportunity to have a televisit of some sort? Anybody? Lots of hands go up again. Okay, so I think that the topic of women, COVID, and telehealth is really a rich subject for us to spend a little bit of time on here today. And we at ACHP are absolutely bullish on telehealth, but we are also very realistic about the limitations and the unknowns. Today, I'm going to focus on 3 dimensions: access, equity, and innovation. But first, let me start with a story. And of course, it's about my mom, right? Because I want you all to like me. So my mother's 83 years old. She lives on her own in Florida, quite independent, in good health for an 83-year-old woman. The pandemic comes along, It's time for her to have her normal check-in with her primary care doctor, and the primary care doctor gets in touch and says, great news, we're going to be able to FaceTime. So I talked to my mother afterward, and I say, well, how did it go? And she says, it was terrific. You know, I loved it. It was so easy. I did it right here on the couch in the living room. And she knows how to FaceTime because she has grandchildren, of course. And she said that she actually felt a deeper connection with her primary care doctor because they shared a little bit more personal experience from the time during the pandemic. She also discovered that her doctor must have a very large house because she was doing the televisit from her very large walk-in closet. But needless to say, my mother was a very pleased patient from the entire experience. Fast forward 1 year later, time to check in with the primary care doctor again, and this time the office gets in touch with my mother and says, okay, Mrs. Connolly, you're gonna come back to the office. Really no particular explanation, but get in your car, navigate traffic, get to the parking lot, come into the building, go up in the elevator, sit in the waiting room, look at very old magazines, wearing your mask, just to have that same check-in with her doctor. So for better and worse, my mother's anecdote actually gives a pretty good broad analogy of what I want to talk to about the state of telehealth today and where we hope that we're going. First, a few fast facts to level set our conversation. After years of flat participation in telehealth, it took off in 2020, largely because the pandemic diverted nearly all care to virtual platforms. You know that, but did you know that prior to COVID-19, just 0.1% of physician visits were telehealth? 0.1%, not 1%. Throughout the lockdown, it shot up to almost 14%. And in the case of outpatient visits, it was 32%. Now, as I'm sure you know, many of those were pretty routine. Rashes, sore throats, a pink eye, a cold, maybe managing a chronic condition such as diabetes. The highest peak was actually in April 2020, when telehealth use rose to 78 times higher than what it was 2 months earlier, and that's according to my friends at McKinsey. Now we've leveled off and it's hovering now at about 38 times the February 2020 rate, but that is still remarkable in a span of about 18 months' time. Even more exciting is that what we're seeing from specialties, and I can't wait to get my friends Andrew and Ritu up here for the conversation because they're the physicians and they're going to be able to share with you some of the incredibly high-end care delivery that can and is now being done virtually if and when the patient chooses that. But think in terms of endocrinology, rheumatology, gastroenterology, and in fact, a good bit of neurological medicine now can and is being delivered via telehealth. So importantly, patients, such as my mother, have been happy. We at ACHP did a survey in the summer of 2020, and of the consumers that had had a telehealth visit, 89% expressed satisfaction with the experience. If you happen to be in an organization that deals with patient experience scores, you know that that is absolutely unprecedented. But still, as I stand here today, there are important questions for each of us to think about. Are we now at a tipping point, or are we going to go backward to pre-pandemic levels? Are we going to take advantage of this great pandemic-era experiment for vital learning about which services are best suited to virtual care, how we engage both patients and clinicians, by the way, and how do we use these exciting new tools to close disparities and reduce costs? So starting with the first of my 3 dimensions, access. As I mentioned, the pandemic brought a boom in telehealth utilization, and certainly some of it can be associated with replacement services. But what was terrific was that we've heard the examples of patients who were getting types of care for the first time ever, most notably mental health care. At the height of the pandemic, 56% of mental health care visits were delivered virtually. And that number remains around 41% of telebehavioral health. Think about that from an access perspective, in particular during this incredible crisis in which so many people are suffering and need that support. Virtual care also, very importantly, opened up greater access to prenatal, maternal, and women's reproductive health services. At Intermountain Select Health, one of our members, they've been using virtual care connections to prevent medevacing patients to Salt Lake, its hub there in Utah. And the case that we love the most is, frankly, when premature babies are born in some of those remote stretches of Utah and Nevada and out west. And rather than having to put those premiums in a helicopter and whisking them to Salt Lake, they can stay there in the local hospital and have the remote telehealth connection with the top specialists in Salt Lake, saving the cost and the strain of the travel for the family, not to mention the baby, saving the local hospital because it keeps business there in the community. So that's the sort of win-win that's possible when you marry technology with the right care decisions made on behalf of patients and their families. Yet we do know that just as the pandemic disproportionately affected women, there's been a gender gap in the growth and utilization of telehealth. Research by our Kaiser Permanente Southern California colleagues found that telehealth visits increased more among men, about 294%, compared to women at about 260% increase. A report by the Kaiser Family Foundation, no connection to KP, found that women's telehealth use during the pandemic also differed by key socio-demographic characteristics. And what they observed was that women over the age of 25, those with a college degree, women that have insurance, or that live in a state that expanded Medicaid, were more likely to have used a telehealth visit than those that did not. Studies suggest that the lower digital health utilization is probably correlated to broader system inequities that I know all of you are very familiar with, and that clearly we have seen exacerbated throughout this pandemic. Women, as you know, are still bearing the disproportionate share of healthcare providing and caregiver activities at home. And we know that unfortunately too many women put their own care, even a convenient telehealth, at the bottom of that to-do list every single day. So we certainly need to work on reaching out to these women to ensure that they take advantage of this incredible technology. And that, of course, leads me to the subject of equity and telehealth. We firmly believe that telehealth has the potential to dramatically improve equity in our healthcare system, reaching populations in underserved communities, people of color, people with disabilities, and many who are living in rural communities. In fact, as I noted, women as well, no matter where they are. Some early indications, again, out of Kaiser Permanente, one of the leaders in this field, they studied the behavior patterns throughout the pandemic, and interestingly, their low-income members had the greatest increase in utilizing telehealth. Their numbers were up 313%. So we know that making this technology available does help some of the least fortunate in our society access care. Partners Health Program implemented a program for patients with intellectual or developmental disabilities to improve their access to care at home. And what they found was that 92% of the patients in that program were then treated in place, and less than 9% of them actually went to the emergency department. So when you think about secure messaging, medication management, often with nifty apps or gamification possibilities, and remote monitoring, you begin to see the potential here for improved access and equity. But we do need devices made available to these individuals, and I want to put in a mention for broadband as well. We are seeing increased dollars by the FCC and Congress on the order of $388 billion toward digital equity, and that's going to go a long way toward closing some of these gaps. But there's still a very important hurdle, and we were actually discussing this last night with Ritu and Andrew and our good friend, a patient advocate, Stacy Hurt. And she was, of course, reminding us that patients, family members, and in fact providers need education and training to master the new technologies. Now, this is not simply a class that people take or we hand them a cheat sheet and that's it, and they're suddenly all going to be telehealth mavens. We know that it requires significant cultural shifts and, importantly, trust. And it will take all of us here and out remote joining us to help make those trusting connections. But without policy action, we will continue to have a patchwork in this country. Let me just give you one example. In Medicare today, thanks to the public health emergency and flexibilities with it, Medicare beneficiaries, about 37 million Americans, can now utilize a telehealth visit. Remember that story about my mother? But if that public health emergency goes away and Medicare doesn't reimburse for those telehealth visits, my mother's back in the office, driving through traffic, sitting in waiting rooms, and providers are having to think about, oh, what sort of insurance coverage does this patient have? Do they have regular Medicare and they can't do a telehealth visit? Or are they maybe in Medicare Advantage and they can? No clinician wants to spend their time sifting through the different insurance options of their patients, trying to figure out how they can best deliver care to that individual. So let me move on to innovation, because I really want to get to our panel conversation. When I think about innovation, I reflect on so many other industries where the goal is better, faster, cheaper. Think televisions, refrigerators, telephones. But when it comes to healthcare, unfortunately, that has never been the case. Not only does healthcare cost more today than it did a few years or a few decades ago, but the prices continue to climb. And this is where I'm going to get on a soapbox for just 1 minute. And I place a lot of the blame for that cost problem in our healthcare system on fee-for-service medicine. Another story for you. When I worked at the Washington Post, if my editor had come and said, "Cece, from now on, we're going to pay you by the word," what do you think I would have done? Written longer stories, not better stories. Not because I'm a bad person, I don't think I'm terribly greedy, but if that was the economic paradigm that I was being told to perform in, naturally, that's what I would have done. And unfortunately, too many of our doctors, nurses, and hospitals today are paid for doing more, not for doing better. So when we think about digital health, what does that mean? Well, part of what we've been seeing in telehealth is a divergence between an integrated, more holistic approach and standalone virtual care. Now, please don't get me wrong. In the early going, the companies that offered ready telehealth networks were essential in opening up access and giving provider relief in underserved and overwhelmed areas. For systems and plans that did not have a telehealth network up and running, such as UPMC, these standalones were an enormous benefit, and they still are in some areas. At first, it was about supply and demand, but now it has evolved to a true continuum of care issue. And here's where I get to another one of my favorite words in healthcare: value. The pandemic and the switch to virtual care helped define what people, patients I'm talking about now, real people, value when interacting with the healthcare system. Better, faster, cheaper is certainly good from their perspective, but that is probably not enough when we think about patients and their family members. We know that coordinated care with common records, the patient history incorporated, that sacred bond between a patient and their physician, seamless transitions and handoffs, they make not only for an easier, smoother process, but better health outcomes. So as we contemplate the next normal, our vision is this more integrated approach, a vision that frankly goes beyond telehealth. Let me mention Group Health Cooperative in South Central Wisconsin, a small but mighty integrated health plan that is now offering multiple virtual on-ramps to care, whether it's a traditional video visit that they can do 24/7, 365 days a year, virtual behavioral health care, and 24/7 nurses hotline, or Kaiser Permanente that is offering perinatal support via telehealth in Georgia, Oregon, and California, to name a few places, that sends mothers at-home blood pressure cuffs and other resources so that they can continue that remote patient monitoring throughout the entire pregnancy. This type of approach can be done outside of an integrated system if you have the right relationships, financial incentives, and most importantly, mindset. So Fallon Health in Western Massachusetts is a terrific example. They are right now taking a good, hard look at how they can best serve challenging populations such as its PACE members up in Massachusetts. And they're relying increasingly on local providers to maintain a consistent and convenient connection to their patients through telehealth. This means much greater patient engagement, which we know leads to better health outcomes. Another example, up in Albany, CDPHP has an AptiHealth program that connects doctors and patients for all sorts of remote assessments, medication management, and most importantly, is encouraging frequent dialogue and communications with the entire clinical care team. And if you stop and think for a minute, that kind of runs contrary to fee-for-service medicine, where they've got you slotted for a 15-minute window, and it is in and out, boom, boom, boom. And they don't necessarily want a lot more follow-up phone calls afterwards or emails or that sort of thing, because they can't bill you for it. But again, under this AptiHealth approach, they are encouraging as much of that dialogue as possible, because they know that it's going to help those individuals stay healthy and out of the hospital. One other terrific example for you, this one from Marshfield, Wisconsin, and it's Security Health Plan's Home Recovery Program. They are treating literally hundreds of conditions today in the home at the choice of the patient and their family. But let me tell you a couple of the data points coming out of this program. 44% fewer 30-day readmissions, a 50% reduction in emergency department visits. Costs have come down 15 to 30%, depending on the ICD code. Now, yes, these are somewhat extraordinary examples, and yes, I could bring you a few more, but the goal here is to make them the ordinary in our future healthcare system. So how are we going to scale these innovations? Well, back in my days at the Washington Post, Woodward and Bernstein always taught us, follow the money. And that happens to be true in the health sector as well. Digital health investment has boomed in 2020 and 2021. And according to our friends at Rock Health, just this year, US digital health startups serving women raised $1.3 billion through August of 2021. And that's nearly double the previous year. I believe that this significant investment in women's digital health reflects the understanding that women's health needs are not being met through the current care pathways. So how do we embrace the endless possibilities of telehealth in a way that benefits patients, caregivers, and clinicians? First is that foundation that I referenced. It has to do with digital infrastructure. Yes, the FCC and Congress have now, through this pandemic, been steering resources into broadband. And it's exciting to see that development. But we know that more is going to be needed, especially in the way of devices and in the way of education and training, so that everyone in this country, not just the haves, but everyone has that digital infrastructure right there at their doorstep. CMS is also continuing to open up reimbursement for a greater number of telehealth services, which again is incredibly encouraging, but I'm going to put a little caveat on that. It's still fee-for-service. And if we want to really advance to the health system of the future, we need to focus on including telehealth in value-based models to make sure that we are steadily transitioning away from fee-for-service. My incredible colleague Ginny Whitman is here, and she's published a paper that outlines two very, very smart, doable financing paths, reimbursement streams to move telehealth from fee-for-service into value-based arrangements. It can be done. It probably takes a 3 to 5 year transition for everyone to make that shift. But that's when you will be able to align the financial incentives in a way that gives patients choices and gives them the ability to access care when and where and how they want. So if we keep seeing improvements like these from our federal partners, and Congress and the administration can take on universal telehealth access and value-based models, we will be able to build that digital infrastructure that is sustainable and affordable. We need policy changes, and I think I'm going to leave those for our panel discussion, but let me just suggest that we need to permanently do away with site of service and geographic restrictions to open up telehealth to all. We also need a cultural shift. Now, even though we've seen telehealth visits peter out just a little bit, I guarantee you the proverbial genie is out of the bottle. We are not going back. But we do have an important role in shaping the future of telehealth. For virtual care to succeed, we need payers, providers, and patients all in this together. Providers need certainty from Congress and payers. Payers need reliability from their provider partners and demand from patients. And patients need coordinated, affordable, high-quality options. We as a collective dedicated to a more equitable, affordable, high-quality healthcare system need to do everything in our power to seamlessly integrate telehealth. So I'm asking all of you here in the room with us and out there in the virtual world today listening, please join us in this effort. Get engaged, talk to people about the ability of telehealth to expand access, improve equity, and give patients and providers the opportunity to really conduct that shared decision-making that's so important to them. I'm going to close with a final thought. Telehealth is not a new type of medicine. It is a tool in the physician's black bag. It should be an option available through shared decision-making, always with the goal of getting the right care at the right time, in the right place, for the right price. Thank you.
Thank you, Cece, for that terrific stage-setting presentation. I'd invite to the panel our two panelists, Dr. Andrew Watson and Dr. Ritu Thaman, who, as they come up, let me give some brief introduction. Dr. Andrew Watson is a physician in the Division of Colorectal Surgery in the Department of Surgery at UPMC and the University of Pittsburgh School of Medicine, and is the Vice President for Clinical Information Technology Transformation in the International Division, the Medical Director of Telemedicine. He's a practicing surgeon, colorectal surgeon, and a leader in applying healthcare technology in the delivery of high-quality patient-centered medicine. He practices nearly a third of his own clinical care using telemedicine to increase access and convenience for patients, and this is in a surgical field. He is the past president of the American Telemedicine Association. As the Vice President of Clinical Information Technology Transformation, Andrew assists UPMC International in developing innovative healthcare information technology solutions to address the needs of UPMC's global partners. Dr. Ritu Thaman is an assistant clinical professor of medicine at the University of Pittsburgh School of Medicine. She's a fellow of the American College of Cardiology and American Society of Echocardiography. Her research focuses on cardiovascular diseases in women. She's the chair of the Echocardiography Twitter Journal Club, a formal journal club on Twitter for which she has developed CME. She is the ASE's social media strategist. She participates in multiple national and international society guideline development and position statements, a member of the ACC Women in Cardiology Leadership Council, and started the Pennsylvania chapter of Women in Cardiology. She's the social media editor for Circulation Cardiovascular Quality and Outcomes and the Journal of the American Society of Echocardiography. She's a national, international figure for social media, for advocacy and education for cardiologists. We're really lucky to have this group of panelists and looking forward to this conversation. Thank you. The first question will, I think, launch from Cece's talk. And in the news today is knowledge of the Biden infrastructure bill. And there are a variety of things that will perhaps optimistically transform in our society. But particular for this use case, can you envision any implications of that infrastructure bill as it relates to telehealth and digital infrastructure, what it might mean for us as we take care of patients in the next 5-10 years? Anyone?
Before I forget, Hai, I have your cell phone. If you haven't seen Hai's cell phone, he's got an old cassette tape sticker on the back, and it says mixtape on it, and it's absolutely fabulous.
I didn't know what my phone was.
It shows you how far we've come.
Thanks.
There's been a push for broadband connectivity, and the ARA funding of 2007 or 8 and the BTOP grant, which was the Broadband Technology Opportunity Program, was an initiative to create infrastructure in broadband. And I hope that we can learn from that, because what we did is we were able to establish very large pathways of fiber, but what we didn't realize was that fiber is extremely expensive to terminate. And as Cece points out, that how we educate patients and families and providers to use it was not part of that. And when I talked to Ritu, we're married, by the way, so you'll see some banter here and there, about disparities in equity in care as well, that the fiber was laid down, but we didn't quite do the last mile, so to speak. And so the hope is that we understand as leaders in healthcare, all of us here, that as we enable broadband and connectivity, we enable the full spectrum of what we're trying to do with value-based healthcare, as C points out, and not just lay down the technology, because I think that's one of the root causes of some of the disparities that we see.
And just to add to what Andrew just said, broadband companies in certain rural places do not want to go there. It's not a financial incentive. But yet, on the other hand, they are influencing politicians to prevent community broadbands to take a foothold. And there's a whole other sort of underbelly of this that is not discussed openly, but it's part of the problem, because if we can't provide the broadband, because the companies aren't going there, but yet they're not allowing people to buy individually and set up their own company in the rural space, it's a political problem, and hopefully, perhaps Biden's new infrastructure will address that.
You know, I hope that's the case. I mean, the dollars are critical, and it will be very positive. On the other hand, Washington has a tendency to grab onto the quick, easy fixes, which is usually write a check. But as Andrew and Ritu are pointing out, if you don't have those other thoughtful elements about care delivery, it's not going to matter if there's broadband.
Right, that full spectrum, right? It's not just about the fiber, it's about the end use. Thank you for that. On the consumer side of this equation, what trends do you see in the coming years in the consumer electronics market that will push this specific field forward, telehealth, remote monitoring, this field of engagement, this field of healthcare?
Well, I'll start from the perspective of health plans, which, you know, certainly our community health plans are excited about the potential of having, for instance, remote monitoring and being able to deliver much more care in the home, because they know that patients prefer it. At the same time, we have a history in healthcare of going out and buying the latest, greatest, snazzy, jazzy gizmo, spending a lot of money on those things, but not necessarily improving health outcomes. So I think there's going to have to be rigor associated with adoption of new, nifty, jazzy gizmos.
And to that end, I will add, CC, I've been working with the ACC and the Consumer Technology Association on a white paper that's coming out next month. And for cardiology-related wearables, we're breaking it down so consumers can actually understand what it is that they're buying and how to really assess the validity, how accessible, and what happens to their data from the wearables, so they can make the most informed decision. So,
I have a question for the audience. Who here owns a drone? Did you raise your hand? I see one drone. That's it, a couple drones?
Wait, can I raise my hand? I have a drone.
It's, what will a cell phone look like in 2 years? We're now buying cars off the parking lot, the used lot, that goes 0 to 60 in less than 3 seconds. So this world of technology and consumer innovation is going in areas it's very hard to predict. Will healthcare be done by avatars? How much artificial intelligence will guide remote monitoring? It's hard to know, but I think there's enormous promise. Much like the bill that Biden has just signed with infrastructure, I'm very optimistic about what consumer electronics will do for us. Now we have this phone that has a folding screen. That's quite impressive as well. But last night in our tweet chat, we had 4 devices running the chat. And it's just the world we live in. But this will trickle down to just the grassroots of patient care. And I think that these companies, Microsoft, Apple, Google, and Amazon, and now Tesla is the next one in there, will drive this. And each one of those has been valued at over $1 trillion.
Next question is, to a degree, we'd like to ground this in reality, even though we're talking about the future. We've talked about essentially conversations and the cognitive aspects of healthcare, talking to patients, patients talking to us. What can we expect, do you think, in the future with respect to the procedures, the measurements, these sorts of things, that not just the talking, but the procedural aspects of healthcare. Do you see us being able to deliver those more effectively in the coming years?
I think so. Sorry,
Go ahead.
Well, go ahead.
Sure. So in cardiology, we're doing teleprocedures, and in Germany it was just shown where by using virtual reality you can insert the eyes of the imager inside the operating rooms where the transesophageal echocardiogram is being done on the patient undergoing surgery, but the imager, the person who's interpreting the images, is 1,000 miles away. And that can be done with just using QR codes. And I think also that, what was the other part, the remote aspect?
Measurement.
Measurement. So the other thing we're doing is with POCUS, which is point of care ultrasound in cardiology, we're using artificial intelligence to guide the actual acquisition of the images. So once that's done, I see that as you being able to go to the drugstore to buy your instrument, just like a pregnancy test, and you can image yourself. That's maybe in 5 years.
Mine's not nearly as exciting as that, so I'm glad. Wish I'd gone first.
All right.
But in the world of surgery, which I live, I've been doing this now since 2004 or 5. And there still are times where, excuse me, that I could use help and assistance, and it's nice to have somebody spot check you. And so in the high-risk procedural world that obviously we live in here at UPMC, at many of our hospitals, having an, excuse me, an eye in the sky is very helpful, where we can do surgical telementoring for tough spots that we all encounter, regardless of skill level. If there's a physician that's not performing as well, they can be well remediated. And also for training, we have to remember the future of healthcare. So I view that this procedural telementoring will be critical, and as C points out, from a payer standpoint in value, this is going to be a key part of procedures of the future. And they're just starting it. The American Board of Surgery has 50 of us piloting a new technology. It's like a black box in the OR, just kind of trying to figure out what's going on. This is the first step towards video-based proctoring and credentialing, which is welcomed.
As we move from thinking about what we're doing in individual encounters to more of the ecosystem of virtual care and the use of technology to enable healthcare, I'd like us for a minute to talk about something that hopefully doesn't take us in too deep and dark of a place, which is the electronic health record. Just a moment of silence for the words electronic health record. And then to continue. The last talk about genetics and genomics talked about the ownership of one's genome and those complex data. One can take that set of thoughts and ideals and extrapolate it across the health record. Do you see us as ever getting to a place where people can amass a longitudinal, lifelong health record, one that they own, that follows them in any tangible way to still allow us to deliver health care? And no could be the answer, I guess.
There is an effort underway called the Commons Project, and full disclosure, I'm on the board. A very interesting and good friend of mine from Oxford, Paul Meyer, started this, and you can find it online. And this is an NGO that's very well funded, looking to find a way to bring data at the patient level or the people level, person level, and also to a big point here, Hai, is also consent about how your data is moved. Because right now your consent is moved everywhere. And the Commons Project is looking to figure out with Apple and Microsoft and Samsung, and actually they're working around the world right now, how do you gather data on using your smartphone as a broker with consent tied to it? It's very early, but it's worth looking at the mission, because these sorts of NGOs are going to be what it's going to take.
And I'll just add to what Andrew just said. I think that until data is legislated, we're not going to get there. Because your EMR and my EMR, if it's across the river, is not, it might be the same, but it's not talking to each other, and that's an essential problem. So when we want to gather and do research on getting big databases, if this hospital systems does not talk to that other ones, we can't combine the data and get the real information that would allow us for every click to make better decisions and ultimately improve patient outcomes.
So on the topic then of the legislative future, the regulatory environment, we've certainly heard from CC about payment, the structure and nature of payment, but also data security, interoperability. Are there other important legislative imperatives to help really make this sustainable and improve moving forward?
The point of service area is critical so that we can practice telemedicine at home. And as C points out, I'm trying to deal with rural and urban.
Urban.
Yeah, urban. It saves some time. Rural and urban designations was artificial even back 15 years ago as well. There is a website called amirural.com, and it's kind of hard to figure out it sometimes. The government certainly is trying here, but the point of service is absolutely critical. And I think state licensing, you're getting into interstate commerce. You're opening up a can of worms at the congressional level, driver's license, and also just commerce in general. So there are vehicles set up for that, the Interstate Compact, through the Federation of State Medical Boards. So I think focusing on third-party payer parity, looking at the place of service are going to be very important.
You know, hi, one other thing I would mention, within CMS there is an innovation center. It happens to be led now by Liz Fowler, a very smart woman who was instrumental in creating the Affordable Care Act. And I think that she is going to inject some fresh energy into that innovation center. And it's incumbent upon all of us to take the really good creative ideas to her, especially around value-based arrangements for the future, and get those taken up to scale very rapidly. I think one of the frustrations with the first decade of that innovation center was they had 1 million pilots. I'm only exaggerating a tiny bit here, but they were all so teeny tiny. And we just have got to get past that and go for sort of a couple of big scale. But I certainly encourage all of you to be familiarizing yourselves with that innovation center and bringing forward your most out-of-the-box ideas.
I think also that the consumers are going to and are driving this, because if there are solutions that the consumer themselves are creating that are going to bypass some of these roadblocks, it might be a quicker solution, and consumers will be willing to pay out of pocket if it's priced right. I think we're already seeing that, you know, if they don't have insurance, or perhaps in the future if insurance is not linked to jobs and employment, there might be freestanding, you know, I'm just going to pay $25 and I'm going to get this service through an app or my question answered. So might be another way around that.
Great. Certainly if there are questions from the audience or online, please feel free to submit them or come to the microphone. And I believe that is Dr. Green.
Yes, Mike Green. The charge was made a few minutes ago that we in medicine adopt the shiniest, brightest, glitziest thing first, and then we have to plead guilty as charged. However, I will say that part of the problem is that there's inevitably a tension between wanting to get the new technology as quickly as possible into use to benefit patients, which often results in a proxy measure for outcome and benefit, as opposed to a longer, bigger study that doesn't rely on a proxy, but rather a hard outcome measure to assess the utility and the value to the system of delivering care. So the question then is, how do you balance the urgency of getting the new technology into use against the time that it takes to find out if it really works?
So I actually was not talking about clinicians. I was talking about your everyday Americans. And this is based on my 25 years as a political journalist, traveling to 48 states, covering elections at all levels. And I believe that the American DNA is to go for the latest, greatest, newest anything. And that also Americans have a notion in their heads that more expensive healthcare must be better, right? They're willing to do economic trade-offs if it's a sweater or a car, you know, what can I afford? That's fine. I'll go for value. But when it's suddenly your own health and mortality, or even more importantly, your family members' health and well-being, you want to spend everything imaginable and try everything. And it's a very natural human trait. We've all seen it and experienced it and probably done it in our own lives. I don't have a good answer for this one because we are humans, and when you're talking about something as personal as healthcare, it's pretty tough to then say, well, I'm just going to go ahead and look at the data here. I mean, the perfect example right now is playing out with the drug Aduhelm. That has been approved as an Alzheimer's therapy despite a unanimous recommendation by the advisory panel to not approve it. And yet I guarantee you, for certain family members of Alzheimer's patients, and I know this because my father was diagnosed at age 58 and lived for 14 years with the disease, you're going to go find that $50,000 or beat up on your health plan to pay that $50,000 if there's even a tiny little bit of hope. And so this is really where the scientific community, clinicians, and policymakers have got to stick to the facts and the evidence. We cannot rely on family members that are searching for hope in these cases.
Just to reiterate with what the question was asking, there are ways and something called just-in-time interventions that are being studied. They're not hard outcomes. For example, in cardiology, we want to look at mortality data, not just time to the next MI. But these are small little 6-month looks at tiny little tweaks, if you will, in wearables, for example. If a text message given at the right time, using the time element, will actually lead to a behavioral change. For example, if you're dealing with obese patients and you're trying to get them to lose weight with an app, the GPS will signify that this person is walking into McDonald's and give them a text message, don't eat those fries, just at that right moment. And looking to see if those sort of nudges will make a difference, because that's what people want to see, but that's not long-term outcomes. We're just looking at very short time periods with that.
Maybe if there was a surveillance photo that sent the image to my husband when I walked into McDonald's.
Yeah.
I'll just comment to Dr. Green's question. I think our traditional ways of evaluating therapies, the placebo-controlled randomized trial is the sort of sine qua non of the strength of evidence. I do think as we evolve in trial design, we can maybe rely on less, I suppose, ossified approaches to the RCT and still gather evidence with still adherence to method and process to evaluate rapidly evolving technologies. I agree that the adoption of technologies for the sake of shininess rather than relying ultimately on outcomes may send us in the wrong direction. And we have several examples in our business of obstetrics that has steered us wrong sometimes. So, question, Dr. Megley.
So I'm coming from the nature of a provider, and I think after a long day of telehealth sessions, there's two things that come to mind that I think about. One is I'm an MFM. We discuss private, confidential issues, and I worry about, for example, doing domestic violence screening in somebody's home, and I don't know who's in the room or in the adjacent room. The other thing that I think about is particularly with all the more recent data on kind of social platforms and the digital age and the information, and I think very personally about when I'm counseling on the COVID vaccine, for example, that the telehealth platform doesn't have the same connection and ritual that potentially an inpatient visit does, just due to kind of our cultural biases based off of what the physician-patient relationship should be. So I'm wondering if you guys could comment on safety, security, and privacy, as well as kind of the digital age and implementation of technology and that connection and that ritual and how to create that in that setting.
It's interesting that physicians have said no, and I'm a doctor, and I'm the seventh generation actually doctor, but we've said no to hand washing, DNA, laparoscopy, transplantation, EHRs, and so it's hard. Culture change is very hard for us. The big one that I think we saw more recently was laparoscopy. We in GI surgery and others stole it from OB-GYN and tried to take the credit from it, but we always are grateful for all you did to set that up for us. But that was a big digital transformation because we're no longer touching the patients. We're using sticks with fire and video cameras on them. And we're going through that same process here in telemedicine. It's just learning how we interact with patients differently and also insurance members. It's just different. The exam's different, the setup's different, and it's much like those ORs. One of my partners in his first laparoscopic colectomies, The Price is Right, came on his video monitor, which is a real screen. So there's technology challenges as well. I would say in general, the platforms are very secure. The government is watching this very closely. I also think that how we understand patients, I did 5 or 6 telemedicine visits in the middle of face-to-face today. And yes, there were other family members in the room I forgot to ask about, but they did speak up. But how we train ourselves as physicians to interact with people virtually, it's a new art and science, just like laparoscopy. But it's very exciting.
I will mention, I serve on an advisory group of Fannie Mae called Sustainable Cities. And we've been talking to them about the importance of incorporating digital technologies into affordable housing for education as well as health purposes. And so one potential solution to your concern about private area for these kind of consults would be almost a community room with a terrific broadband hookup that people could use for those sorts of things. So I think it is a concern that we need to take seriously, but that it can be addressed. I also just suspect that there's a generational divide here. I mean, how many of us know teenagers that are ready to take a photo of that rash and put it out there on the World Wide Web and crowdsource, hey, what do you think this is? So, I'm a little old school and don't want any photos like that out there, but it's amazing how attitudes change.
I think also that we're learning how to communicate in this platform, like building the car and driving it at the same time. And I think in particular, when we're dealing with female patients, this domestic violence issue, which has resurged or come to more attention during this COVID pandemic, is a real concern that you raise. And I think that we're going to evolve into new signs or better communications. For example, I don't know if you heard about the girl that was abducted, but then she used a sign that somebody had seen on TikTok and led to her being saved. And it was just some very small little thing. And someone recognized it. And I think for domestic violence, particularly, those kind of things will evolve out of necessity. Because if we're seeing a patient and their abuser is in that room, that's our greatest fear, that we're gonna make the situation worse. And we don't wanna do that. So I think that will happen.
Just real quick, with respect to intimate partner violence, one thing we at UPMC have discovered is that beyond perhaps live synchronous visits, whether face-to-face or via telemedicine, are not the optimal strategy to generate disclosure. We've noted that our own platform, which is a secure, on the patient side, patient-facing app called My Healthy Pregnancy, identifies intimate partner violence, risk for intimate partner violence, much more capably than is done in the clinic, whether face-to-face or remotely. And the nature of what individuals are willing to disclose, I think we'll learn more about that as these devices and tools are in their hands. But our own experience is that we're actually much better at identifying intimate partner violence. When we use a digital approach, it's just not actually talking to the patient that time. Thanks. And we are, unfortunately, out of time. Thank you all for your interest and enthusiasm, and thank you to our panel. Join me in thanking them. Thanks. Thanks.